Hi guys, welcome back. We shall now be talking about aspects related to hypertension. The prevalence of hypertension is gradually increasing in our country as well as globally, and this is one of the primary causes why the incidence of heart disease has suddenly shot up, and then stroke incidence is also increasing. So if we are able to control hypertension, then the incidence of coronary artery disease and stroke will also substantially be reduced. If you look at this recording that I have shown here before you, this represents ambulatory blood pressure recording for a normal person versus a hypertensive patient. The black tracing is for a normal person. Our blood pressure is never constant. It keeps on fluctuating all the time, and the lowest values of blood pressure are recorded when we are sleeping at night, when our muscles are relaxed. The magnitude of fall of blood pressure at night time when we are sleeping is to the tune of approximately 10 to 20%. But as we wake up, the blood pressure tends to rise. Vasoconstriction is more in the early morning hours, and higher blood pressure values of you and me. What I mean by higher is not more than higher than normal. I mean, as compared to the diurnal fluctuation, higher values are reported at 12 o'clock in the noon. So that is a question for you guys from physiology, that blood pressure values are highest at what time of the day? That is 12 o'clock in the noon, and are rather the least at night time, especially like early morning 3 a.m., 4 a.m. is when the blood pressure values are significantly reduced by 10 to 20%. Now, if you consider ambulatory blood pressure recording of a hypertension patient, you will notice that not only the BP value is also higher, in fact, there is no nocturnal dip that has been shown here. The dip may be present or will not be present. So I would like you to remember the fact that if you are seeing an ambulatory blood pressure recording of a person and you see that there is an attenuated or no nocturnal dip, it means the fact that in this person, hypertension process has not only started, but he will definitely have an increased cardiovascular mortality. The possibility of him developing MI or stroke are substantially increased. The second importance of learning this data is that when should medication for hypertension be taken? Then medication for hypertension should be either taken as first thing in the morning or should be taken at night, so that the morning increase of blood pressure that is occurring, that is vasoconstriction, as I said, is more in the morning hours. So the morning spike that is occurring can be prevented. So hypertension medication should ideally be the first thing in the morning. You see, there are two aspects I want to highlight. One is early diagnosis of blood pressure. If you're recording blood pressure the standard way in your clinic, patient will come, you will put in a BP curve, record blood pressure. If it is elevated, you will ask him to come again. Then you will take a mean of 2-3 values and say, okay, you are hypertensive, you are not hypertensive. That's the primitive way. Currently, they are saying that go in for ambulatory blood pressure recording and then take an average value. If it is more than a certain cutoff, it means that the person is hypertensive. Early identification of blood pressure is recommended by ambulatory blood pressure recording. If you achieve good control of hypertension in a patient, then the mortality rates can significantly be reduced. What I mean by mortality rates being reduced is that there would be a reduced incidence of acute coronary syndrome, reduced incidence of stroke and heart failure. I will also add some figures here that will make you more comfortable reading this information. Good control of blood pressure reduces coronary syndrome mortality or incidence of coronary syndrome by 25%, stroke incidence by close to 30%, and heart failure incidence by a substantial 50%. Hypertension patients can develop left ventricular hypertrophy and sometimes can decompensate, and the incidence of that will be reduced by a huge 50%. Well, what is the normal blood pressure value? The textbook says there is no normal value defined for, or one particular value defined for everybody, because everybody's body composition is different, height, weight, build, gender is different. So he says the normal value can vary for all. But traditionally, it has been shown that if the blood pressure of a person, irrespective of nationality, is more than 115 by 75 millimeter of mercury, the higher it will go above this value. The higher the blood pressure will go above this value, the more will be the incidence of problems for this person in future. Current studies have shown that 20 millimeter rise of systolic blood pressure above 115, diastolic blood pressure rise above 75 millimeter of mercury, this increases cardiovascular risk for the patient. So after all, what should be the cutoff beyond which we say hypertensive? The current edition of Harrison says 140 by 90, whereas American Heart Association mentions 130 by 80. So we will learn both the classifications here. According to Harrison, he has mentioned the fact that pre-hypertension, the blood pressure values are between 120 to 139 and diastolic blood pressure values are between 80 to 89. Stage 1 of hypertension is 140 to 159, diastolic in the range of 90 to 99, and stage 2 would be more than 160 by 100. This is what I would like you to answer in the exam, because this is what Harrison is saying. American Heart Association has, however, lowered the cutoffs. One, instead of using the word pre-hypertension, they've used the word elevated blood pressure. Stage 1 word has been preserved, stage 2 word has been preserved, but the cutoffs are not the same. Elevated blood pressure is between 120 to 129, mark my words there, not 120 to 139, 120 to 129, and diastolic less than 80. The cutoff for hypertension now has been changed by AHA as 130, though most of the experts are not agreeing to this, because this would mean that almost 45% of the world population will become hypertensive and they will take treatment for it. And you would see a lot of people with blood pressure 130 by 80, they're asymptomatic and they may remain asymptomatic for whole of their life. They may never have a cardiac issue. So I would say like this, that the AHA classification has come, we should study it, no doubt about it. But in the exam, I would still like you to answer as a cutoff of 140 by 90 for diagnosis of hypertension. Please appreciate the fact that the cutoff of 140 by 90 according to AHA is stage 2. So Americans are being overtly aggressive in management of hypertension, maybe because in their country hypertension has become such a problem that they have to treat it on an epidemic scale, and that is why they have lowered the cutoffs. But when it comes to India, when it comes to the rest of the world, when it comes to the remaining data, this is the cutoff that I would like you to answer. So I know it sounds a little irritating to read two different classifications of the same disease, but then you see, if in a question he does not specify anything and just ask you cutoff, then this is the value to be given. In fact, Harrison has mentioned one more thing which will make you understand that why all this discussion is useless. He says, why do you waste your time taking these isolated blood pressure values and taking a mean value, asking the patient to come again, then do BP charting of a patient? He says, go in for ambulatory blood pressure recording. If in ambulatory blood pressure recording, the awake blood pressure of the patient can be checked, sleep blood pressure of the patient can be average, can be checked. If the awake blood pressure of the patient is more than 135 by 85 millimeter of mercury, listen to this very carefully. He says the current concept is go for ambulatory blood pressure recording, that is continuous blood pressure recording. If the awake blood pressure average is more than 135 by 85 or the sleep blood pressure value is more than 120 by 75. Please pay attention to these numbers that I'm saying right now, because if you've not read this might look like a shocker to you. 120 by 75, yes, average sleep blood pressure more than this value corresponds to clinic blood pressure of at least more than 140 by 90 millimeter of mercury. You see, in the hospital, the person is a little anxious on seeing you, your stethoscope, the white coat of yours, person might feel anxious, so the blood pressure values will be slightly higher. And in fact, you would have noticed this also. Now, the blood pressure apparatus that is available in the house, like if you are having a portable blood pressure recording device in your house, you will notice that on the flat dashboard of that, the cutoff for hypertension is not 140 by 90, it is 135 by 85. So home BP recording is lower as compared to the office BP recording of 140 by 90, because as I said, sympathomimetic stimulation would come. And at the same time, I also want to tell you that it is not that home BP values are useless. They are useful, and home BP values can also be used to identify hypertension in a patient, because if home BP values are elevated, office BP values will obviously be elevated. And to bypass all of this, cutoffs and everything, he just says go in for ambulatory recording, and these are the cutoffs that I would also like you to remember over and above the data on the top: 135 by 85 and 120 by 75 for average awake BP and sleep BP. This is ambulatory blood pressure recording that you have to remember. Once you get a hang of this, then I want you to remember that the overall most common cause why do you have development of hypertension is idiopathic, that is primary hypertension, it is essential hypertension. But if he says what is the leading cause of secondary hypertension in a patient, it is renal causes. Though there are some studies which are saying obstructive sleep apnea has become the leading cause. That's what the Americans are saying, because in America obesity is so prominent. All Americans are so hefty and so fat after eating burgers all the time. So obstructive sleep apnea is like an epidemic in America. Everybody in America has started using a CPAP machine after the age of 35, 40. Men and women both, husband, wife, both are sleeping and both are using a CPAP machine at night. So in America, obstructive sleep apnea, but for the remaining part of the world, in substantial population in India, it is still renal causes. And when I say renal causes, guys, it is renal parenchymal causes which are more common as compared to renovascular. So renal artery stenosis is a separate topic that I've dealt in the kidney topic. When you scroll through, you will notice a separate small lecture on renal artery stenosis. Here I'm saying renovascular causes are important. Then an isolated question that came was congenital cardiovascular cause of hypertension. This would be answered as coarctation of aorta. For coarctation of aorta, I can just draw a line diagram here that will make you more comfortable remembering this. You see the leading site of coarctation of aorta is aortic isthmus or descending aorta, or I can say distal to the origin of the left subclavian artery. As you can see in this representation, that because very less blood will be going into the legs of the person. So if you record the BP in coarctation of aorta in the legs, it will always be lesser. Patients of coarctation of aorta, they will always be having muscle wasting in the legs, and the BP in the legs will always be lesser. Why? Because of the fact that less blood is going to legs. But if you will record the BP in the arms of the patient, then in the upper limbs of the patient, you will always notice that the BP will be higher. Why? Because the function or formula for blood pressure is cardiac output multiplied by peripheral resistance, and if the aorta is narrowed, then peripheral resistance is upgraded, so therefore the BP will also be higher. So in you and me, the blood pressure in the upper limb and lower limb is reverse. If you check in a normal patient, blood pressure in the upper limb, it would be less than 120 by 80, usually 115 by 75 ideally. The way you are sitting on a chair, if you're lying down in the bed separate, if you are sitting up in a chair with your legs are dangling, if I record your BP in the legs, your BP will be slightly higher in the legs. It would be about less than 140 by 80. The BP in the legs of a normal person is higher because of gravity. I repeat my statement, blood pressure of a normal person in the legs is higher because of gravity, but in coarctation of aorta, it is opposite. So that's the MCQ statement for you, that reversed situation, that is BP higher in the upper limb as compared to lower limb, is a feature of, the answer is coarctation of aorta. Repeat my statement, blood pressure opposite or normal, that is higher in the upper limb as compared to lower limb, is a feature that is seen in coarctation of aorta. At the same time, you can also be asked questions with respect to unequal BP between the left and the right arms. Blood pressure between left and right arm mostly tends to be equal or can be slightly different, less than 10 millimeter, but substantial difference, unequal BP between left arm and right arm, is a feature that is encountered in the following diseases. One is called as pulseless disease or Takayasu's arteritis. This is also one of the important causes of renal artery stenosis in India. So Takayasu's arteritis has a propensity to involve the subclavian arteries, and the ostial narrowing that occurs because of it. It narrows the origin of the artery. So less blood supply in the subclavian artery can cause unequal blood pressure between left and right arm. Another cause for such manifestation is supravalvular aortic stenosis. That's just a terminology that I want you to remember for today. SVAS, supravalvular, not valvular. I'm talking about SVAS, supravalvular aortic stenosis, will have unequal BP. The third condition is coarctation of aorta. Again, there are two varieties of coarctation of aorta, preductal and postductal. So the preductal variety can have unequal BP between the left and the right arm, whereas blood pressure higher in the upper limb as compared to lower limb. This is a feature that is found in postductal variety of coarctation of aorta. So do remember this technical word also. Postductal variety of coarctation of aorta causes BP to be higher in the upper limbs as compared to lower limbs. And if it is difference between the two limbs, then the difference between the two limbs is to be remembered for the preductal variety of coarctation of aorta. Once we have remembered some of these common aberrations that I've described before you, then it would be my job to highlight secondary causes of hypertension, which are usually asked in the exam. So we will talk about them individually. The first one on the agenda would be to discuss renal parenchymal disorders. You see, when person is having chronic kidney disease, CGN, then person will be having a high renin state that will contribute to hypertension in the patient. So it could be chronic kidney disease due to diabetes mellitus, polycystic kidney disease which has degenerated, obstructive uropathy because kidney parenchyma is damaged, so therefore renin will start increasing in the patient. Renovascular causes are also to be considered. The incidence is however rare. The names to be remembered is fibromuscular dysplasia and atherosclerotic renal artery stenosis. Both will contribute to high renin hypertension in the patient once again. For fibromuscular dysplasia, we have a particular chain of beads appearance on our renal angiography. Then is metabolic syndrome. This has become an epidemic in America and is soon becoming in India also. The features of metabolic syndrome are four. One, the person will be having centripetal obesity. His abdominal circumference will be substantially increased. The second feature that you get in this person is insulin resistance. The third feature is development of hypertension. And the fourth is hyperlipidemia. Metabolic syndrome is excess of four things. No, everything is more. Weight is more, sugar is more, blood pressure is more, fats is more. This is like a short, hefty guy. He's more broad than he's more tall, and he's having high blood pressure because the peripheral resistance is increased. The high fat in the body will contribute to insulin resistance. So his fasting blood sugar can be between 100 to 125, and his triglycerides are substantially elevated. So cardiovascular risk profile is increased in the patient. Linked to this would be OSA, obstructive sleep apnea. In obstructive sleep apnea, during apneic episodes, what happens is that the oxygen to the body is cut off, so there's a bradycardia. Now, when there is hypoxia, the person will then try to breathe in. There will be a cortical arousal, and during cortical arousal, when oxygen will go in the body, suddenly there's an acceleration of the heart rate. So what happens in OSA is that as he will snore, the snoring will become louder, and when the airway is cut off, there's a bradycardia. Then there's a cortical arousal, the oxygen goes in, there's an acceleration. So heart slows down, accelerate, slow down, accelerate. So there's a lot of stress on the heart. This stress on the heart manifests in the form of development of hypertension in the patient in the long run, and a development of left ventricular hypertrophy also. So obstructive sleep apnea is characterized by fluctuation in the heart rate of an individual when he's sleeping, and the heart rate changes from bradycardia to tachycardia range. Every time there's a cortical arousal, there's a tachycardia. Every time there's a apneic episode, there's a bradycardia in the patient. So this fluctuation increases stress in the body. The catecholamines cause vasoconstriction. The stress on the body substantially increases. Next on the agenda would be endocrinological causes which can contribute to high blood pressure in a patient. One is hypothyroidism. In hypothyroidism, heart rate is less, but still BP is higher. Why? Because there's a myxedema that increases the peripheral resistance of the body. So hypothyroidism most of the time causes isolated diastolic hypertension. If you have seen hypothyroidism patients in your clinic, you will notice that most of the time in these patients, it will be a systolic of 120, diastolic of 100. So that's an MCQ statement that I wanted to remember. Isolated diastolic hypertension, most common cause is essential obviously, but then an endocrine cause to be remembered is hypothyroidism. Then can be thyrotoxicosis, that is easy to comprehend. Thyroid hormones contribute to sympathomimetic profile, so that will result in increase in blood pressure of the patient. Rare causes among this could be primary aldosteronism. That would mean that the patient could be having a bilateral adrenal hyperplasia, or he could be having a tumor in the adrenal gland. So excess production of aldosterone will be responsible for high blood pressure in the patient. Pheochromocytoma I'm not mentioning in this particular list, one because it is relatively rare, and it is rather having a genetic basis also, because pheochromocytoma can be associated with multiple endocrine neoplasia, MEN to A and MEN to B. So I'm not mentioning it in the list of secondary, though it is also an endocrine cause. The next statement of mine is very interesting: neurogenic causes of secondary hypertension. One of the causes to be remembered and is worth remembering for questions is spinal cord transection. In the exam, he has asked spinal cord transection at what level will usually result in a high blood pressure. Then remember, spinal cord transection at T6 or above results in unopposed sympathomimetic flow to the heart, which results in a sudden spike in blood pressure of the patient. Even raised intracranial pressure, when you read about Cushing reflex is bradycardia with hypertension. So sudden raise of intracranial pressure, spinal cord transection at T6 or above are two important neurogenic causes. Though rare, but I'm mentioning two more here. One is porphyria. He says that symptoms of porphyria can mimic that of pheochromocytoma. It could be sudden sympathomimetic activity in porphyria, which could be explaining the high blood pressure. Second will look very surprising if you're reading for first time lead poisoning. Why in lead poisoning? Because they've shown that lead poisoning causes increased activity of the ACE enzyme. If there is more activity of the ACE enzyme, there is more production of angiotensin 2, and you know angiotensin 2 causes vasoconstriction in a patient, so it increases the blood pressure of a patient. We will now look at some Mendelian causes which are responsible for development of hypertension. Though they are relatively rare, but still MCQ is important, so we need to practice them, and they all contribute to secondary hypertension. The first on the agenda would be called as Liddle syndrome, autosomal dominant condition. Let's see what's the problem. In these patients, the epithelial sodium channel will be working more than normal. You know the receptor for aldosterone is epithelial sodium channel. If it will work more than normal, it will get more salt and water in the body. More salt and more water will mean that there will be expansion of the plasma volume that will explain the high blood pressure of the patient. Simultaneously, there will also be an exaggerated loss of potassium and hydrogen that will explain metabolic alkalosis. Liddle syndrome, the disease is not due to the hormone but due to the overactivity of the channel. There is a gain of function of ENaC, epithelial sodium channel, which explains hypertension with hypokalemic alkalosis in the patient. For management of this patient, we will have to use a drug that is by the name of amiloride. It will block the epithelial sodium channel and thereby circumvent the high blood pressure of the patient. You have to compare Liddle syndrome with Gordon syndrome. In Gordon syndrome, which is again autosomal dominant, the problem lies in the distal converted tubule of the patient. The mutations which are involved here are called as WNK1 and WNK4 mutations. Now let us see what is the problem with them. There is again a gain of function, but this time the gain of function is of a channel on which thiazides act. You're aware that thiazides act on sodium chloride co-transporter and they inhibit the sodium chloride co-transporter, so salt and water is lost from the body. Here there is a gain of function of the thiazide dependent sodium chloride co-transporter. As I said, gain of function, so you can understand that more sodium and chloride will be coming back in the body, and that will explain the high blood pressure that will manifest in these patients. Apart from Liddle and Gordon syndrome, the third cause to be remembered is polycystic kidneys. It can be autosomal dominant and autosomal recessive variety. In adults, it is mainly autosomal dominant. In pediatrics, it is autosomal recessive. The destruction of the parenchyma of the kidney will decrease the GFR, so therefore the renal values will start increasing in the patient. So is the status of pheochromocytoma. This is again associated with multiple endocrine neoplasia type 2A, that is Sippel syndrome. It can be associated with multiple endocrine neoplasia type 2B, von Hippel-Lindau syndrome, and also with neurofibromatosis 1, and all of these are again autosomal dominant associations. The ones that I will teach you subsequently are autosomal recessive, but let's just make a recap of the autosomal dominant Mendelian causes of hypertension that we've discussed. And this particular slide, Liddle, the problem is gain of channel of ENaC, epithelial sodium channel. Gordon, it is gain of function of thiazide sensitive sodium chloride channel. Polycystic kidneys is understandable autosomal dominant in adults related to chromosome 16 and chromosome 4, that is PKD1 and PKD2 gene. Pheochromocytoma related to Sippel syndrome and other allied issues. They're all autosomal dominant, and the ones that I will discuss with you next will be autosomal recessive. So let's look at point number 5 of the discussion. This flowchart here talks about adrenal steroid synthesis, and this is a chart that you are aware from your biochemistry days for synthesis of mineralocorticoid, glucocorticoid and sex steroids. What I am saying is that if a person will be having a deficiency of this enzyme by the name of 17-alpha hydroxylase, then you can see that this pregnenolone will not be converted into 17-hydroxypregnenolone, and therefore this pregnenolone will be diverted in this pathway towards the synthesis of aldosterone. I repeat my statement again, because there is a block in the enzyme here, the metabolism will not proceed in a horizontal direction, it will proceed in a vertical direction. That is, more of the fuel will be diverted towards the synthesis of aldosterone, and the production of aldosterone will increase. So the condition that I'm talking about, and is an autosomal recessive condition, is 17-alpha hydroxylase deficiency. This topic 17 alpha hydroxylase has also been mentioned in the topic of endocrinology under the adrenal gland section, where I've talked about CAH, that is congenital adrenal hyperplasia. So you can have a look at this, or you can go to the pediatric section of the app and you can read congenital adrenal hyperplasia from the pediatric part or read it from OP Ghai. But 17 alpha hydroxylase and 11 beta hydroxylase, in both of them the problem is that the cycle is not able to function normally, and the most of the product, that is the basic fuel for synthesis of all steroid hormones, is cholesterol in the adrenal gland. So this cholesterol and the products are diverted towards the synthesis of excess of aldosterone, and therefore these are autosomal recessive causes which would be responsible for development of high blood pressure in the patient. Do notice here I did not say the word 21 hydroxylase deficiency, because 21 hydroxylase deficiency is deficiency of aldosterone. There's a hypotension present in the patient, so that could also be questioned, that he could mention or change the number of the enzyme. So 21 alpha hydroxylase is less aldosterone, and the remaining two that I mentioned would be having relatively increased blood pressure. So let's have a look at some causes of hypertension that I've explained to you. You see, overall the leading cause of development of hypertension is obviously essential hypertension, but then renal causes are to be considered mainly parenchymal. Congenital causes are like coarctation of aorta, which could be present since birth. And then I have mentioned some common causes that you should be able to rule out when you're evaluating the patient. When a hypertension patient is in front of you, you should rule renal, parenchymal, renovascular. You can look at the weight of the patient, whether he is having any evidence of obstructive sleep apnea. By history of the person, they would be disturbed sleep. He will say, I never feel fresh in the morning, because every time when he was sleeping, he was having hypoxic spells. So every time there's hypoxia, there's a nocturnal awakening. So he will not be able to sleep properly at night, so he'll never feel fresh. Then endocrine disorders have to be picked up, and then a few rare neurological causes were just mentioned to, I would say, spice up the discussion, or rather make you more oriented towards the rare causes. That should also be remembered. The Mendelian causes is a highly important part of the discussion. It's mainly that Mendelian causes have started to be asked, so that's why I had to update this lecture primarily. Otherwise the cutoff and everything is same as far as the current edition of Harrison only. Let us now look at the baseline tests that should be done in any newly diagnosed case of hypertension, and the first test to be done is echocardiography. Why? Because I want to check for evidence of left ventricular hypertrophy. Though I can do X-ray also as a low-cost option, but if I want to pick up a concentric hypertrophy of the left ventricle, strain on the left atria, then it's a wiser idea to do a echocardiography right away, provided constraints are not there. Fasting blood sugar will be done in the patient along with lipids to check for coexistent morbid conditions and presence of metabolic syndrome. Electrolytes are run so that you can check up or evaluate potassium in the patient, because a lot of patients could be having hypokalemic alkalosis. So the hypokalemia component in the Mendelian forms can be picked up by electrolytes. The hormone test that is usually performed is a thyroid function test. To optimize the cost, you can do a baseline TSH initially, and then if required move on to going in for T3, T4. To evaluate the status of the kidney, because kidney is very peculiar in a sense that kidney is gonna be the end result of target organ damage, and it is also the trigger for development of hypertension. So urine microscopic examination along with albumin excretion rate, because albumin excretion rate is present, which was formerly called as microalbuminuria. So if albumin excretion rate is having a value of 30 to 300 milligram, that means the fact that person is already having a damage to the kidney, either due to hypertension or maybe due to diabetes. So we need to scan the patient for comorbid condition like diabetes mellitus. And blood urea nitrogen and creatinine will also be deranged, especially if diabetic nephropathy is already present in the patient. It will cause a high renin hypertension in the patient. Once we done a baseline workup of the patient, it would be time for treatment of the patient. The drugs that we are using for management of hypertension are ABCD, that is ACE inhibitor, beta blocker, calcium channel blocker, and diuretic. So for management of hypertension in a patient, the first thing that is advisable for the first 3 to 6 months after diagnosis is a lifestyle modification. This would include dietary approaches to stop hypertension, which we call as DASH. I repeat again, DASH is dietary approaches to stop hypertension, which would mean that he has to cut down on the salt component, increase the potassium intake in the diet, stop taking saturated fats, reduce carbohydrate consumption, increase physical activity simultaneously. So combination of increased physical activity, reduction in sedentary lifestyle, dietary approaches to stop hypertension to be instituted in a person, awareness regarding side effects of excessive alcohol consumption to be explained to the patient. And I mean, if after 3 to 6 months you've tried all these and still the blood pressure is not controlled, then you will have to start drugs. Now, if the person is less than 55 years of age, then the first line drug to be introduced is ACE inhibitors. If there are side effects like dry cough or angioedema, you might have to switch over to ARB, that is angiotensin receptor blocker. And if the age of the patient given in the question is more than 55 years of age, then the drug that is recommended for the patient is calcium channel blockers. Suppose in a 40-year-old man you have started ACE inhibitors but BP is not getting controlled, then you should add CCB. If it is still not getting controlled, you should add thiazide diuretics to the patient. And if you are given 3 classes of drugs like these and still the BP is uncontrolled, then the definition of resistant hypertension would come. Resistant hypertension is defined as uncontrolled hypertension with 3 classes of antihypertensive medication. The textbook mentions that in the 3 classes of antihypertensive medication that has been given to the patient must include is thiazides, and if BP is not controlled in spite of all of this, then the additional drugs that you should use are either alpha blockers or you can start adding beta blockers also. So the recommendations are like, first go to the maximum dose of ACE inhibitor, not controlled, go up to the maximum dose of calcium channel blocker, combination of the two not working, add up thiazides in the patient, and you will be able to achieve a decent control in the patient. These are obviously rare aspects which could be occurring in a patient. However, in the exam, they can also ask you regarding usage of these drugs beyond the aspects that I have mentioned on the previous slide. Like for example, they gave a scenario that a person is having post-MI status. He has survived the acute coronary syndrome. He has been identified as a hypertensive patient. What drug will you start in the patient? Out of the options of ABCD for post-MI patients, first line intervention that should be done for hypertension is ACE inhibitors. Similarly, ACE inhibitors are also to be used for patients who are having heart failure with reduced ejection fraction. REF stands for reduced ejection fraction. They are also the first line drugs for diabetic nephropathy. They reduce the progression towards end-stage renal disease, and also for patients of ischemic nephropathy. That would be renal artery stenosis in a patient, but should be unilateral one, not the bilateral one. You will notice that in the previous slide I did not speak much about beta blockers, because in idiopathic or essential hypertension, beta blockers alone do not have very significant role. When would you be giving beta blockers to a hypertension patient like nebivolol, carvedilol, is when a person has been diagnosed to be having chronic stable angina, that is, he is having a double vessel disease or triple vessel disease and is undergone a coronary artery bypass grafting or is scheduled to undergo coronary artery bypass grafting. That is when we give beta blockers to our patients. The next statement of mine is extremely important. If he says congestive heart failure due to systolic malfunction, you see in heart failure of the chronic variety, consumption of oxygen should obviously be regulated. You see, the heart is not working properly, it is not getting sufficient fuel, and if you can conserve the fuel by giving a beta blocker, the performance of the heart will increase. So for beta blocker, remember the 2 C's that I mentioned before you, that is chronic stable angina and congestive heart failure due to systolic malfunction, where you want to conserve the fuel of the heart, is where beta blockers are currently recommended. The beta blockers that I'm talking about here are cardioselective beta blockers, not non-cardioselective. Please remember, I'm not talking about propranolol. I'm talking about cardioselective beta blockers in this case. Another category that is quite frequently quizzed nowadays is spironolactone, that is aldosterone antagonists, and their role in management of hypertension. They have been found to be extremely useful for patients of heart failure with preserved ejection fraction. So get my words right. ACE inhibitors are for heart failure with reduced ejection fraction, and aldosterone antagonists are useful for it's not that aldosterone antagonists cannot be used in heart failure with reduced ejection fraction, but lots of time in reduced ejection fraction person might be very sick initially, so he may not be able to tolerate diuretics substantially. So we would be rather using aldosterone antagonist initially for management of patients of heart failure with preserved ejection fraction. Another category that is asked is alpha blockers. You will answer this for hypertension with patient having prostatism symptoms, that is benign prostatic hyperplasia, and alpha blockers also have to be used in patients of pheochromocytoma. In fact, in all patients of pheochromocytoma, first you should give alpha blockade, then go in for beta blocker. It is alpha plus beta. If you do reverse, then there could be hypertensive crisis in the patient. Why that is so is because beta cause vasodilation, alpha cause vasoconstriction. If you will first give beta blocker to pheochromocytoma patient, then vasodilation of beta will be blocked and alpha will be unopposed, so that will spike the blood pressure of the patient. So these are some aspects which I want you to remember specifically, out of which especially 3 statements which I'll repeat once again are: post-MI patient, it is ACE inhibitor. If it is chronic stable angina or heart failure during systolic malfunction, then it is beta blocker which is to be answered, and that is a cardioselective beta blocker which is to be answered. We shall now talk about some special situations which are related to hypertension, and the 2 terminologies that are always asked or can be asked are hypertensive urgency and emergency. Now my point is that on the internet or in various classifications on the internet publications, the cutoff is given for urgency and emergency as 180 by 120 millimeter of mercury. However, in Harrison there is nothing given for urgency and emergency as a cutoff. In current medical diagnosis and treatment CMDT 2019, I have posted a reference here straight away, because the common queries that I get from most students is that on the internet or in classifications it is given as 180 by 120. In fact, some of the apps have also used the same internet data and saying 180 by 120. But I personally feel that we should not use internet based data, and textbook data should be given more importance. So CMDT has given a cutoff of 220 by 125. I will just read what CMDT says. He says hypertensive urgency where blood pressure is greater than 220 by 125 but life-threatening end organ damage is absent. And emergency is where the end organ damage is present with this cutoff. So this is my textbook reference that I have given you, and I would recommend you to answer, though again you might feel a little uncomfortable first time listening to this, because today I've taught you 2 cutoffs for hypertension, 140 by 90 by Harrison, 130 by 80 by American Heart Association, and I'm also teaching you 2 cutoffs for urgency emergency, 180 by 120 by internet, and CMDT is 220 by 125 millimeter of mercury. In urgency there is no life threatening, so I'm writing minus, no TOD, that is there is no target organ damage in a person. Whereas in case of an emergency, target organ damage like retinal exudates or papilledema or fibrinoid necrosis of the kidney, flea-bitten kidney, microangiopathic hemolytic anemia, I mean something will be given in the question that will tell you that this is a complication related to hypertension. The important organs which are affected in hypertension can be heart, brain, eyes, kidney. In fact, all organs can be affected. So that is why the word emergency is described, or crisis word is written, or emergency word is written. So the cutoffs are again the same, 220 by 125 millimeter of mercury. In some books it is even 130. So that is why, because I'll put it like this, why these different books are giving different is because different studies have been done on different populations. Genetic makeup of Indian is different from American, from Japanese. Japanese hardly have heart disease. Indians have large amount of heart disease. You go to Europe, you go to Ukraine, again a huge incidence of coronary artery disease, cirrhosis. So I mean country to country data can vary. That's why these disparities are there. So you don't need to be too affected by it or too bothered by it. There will definitely be evidence of TOD or target organ damage in a patient. Like one hypertensive emergency that I can at the moment mention before you is malignant hypertension. You would have read about this in pathology also, that is fibrinoid necrosis involving blood vessels which are supplying the retina or supplying the brain or supplying the kidney, or general blood vessels are affected. The manifestations in these patients could be because retina is damaged, so they could be either retinal exudates or they could be papilledema described in a question. Damage to the brain can again contribute to encephalopathy in a patient, because you see when the blood pressure is very high, the blood vessels of the brain, they undergo protective spasm. That spasm can contribute to cerebral ischemia, encephalopathy. There would be deterioration of urea creatinine of the patient, and the blood vessels might damage the RBCs, causing a microangiopathic hemolytic anemia. Why is malignant hypertension caused so? It's called as malignant because the mortality rates are exceptionally high. The mortality rates approach 50%. If you don't treat malignant hypertension, the mortality rates over the next 6 to 12 months are a huge 50%. So we call it malignant hypertension. And how do you suspect that somebody is having malignant hypertension? Well, somebody is a known case of hypertension. He's also under your care, he's also on medication. But in spite of medication, the blood pressure is still showing a progressive rise. I would like to say that if you get a clinical situation like this in your career, in your practice, in the exam, then two differentials always have to be thought. If abrupt rise of BP is occurring in a known case of hypertension as he's becoming older, one could be that he's having atherosclerotic narrowing of the osteo of the renal artery and he's developing a renal artery stenosis. Don't continue ACE inhibitors in that person, because if the same person will develop bilateral RAS and you will give ACE inhibitors, his BP can crash, and then in those circumstances there can even be acute kidney injury triggered in the patient. The second clinical scenario where you can have an abrupt rise of BP in a known case of hypertension is malignant hypertension. Therefore, in these patients you have to initiate aggressive treatment. I am assuming the fact that you have ruled out cocaine abuse in the patient. Recreational drug abuse always has to be ruled out before you say that person is having a hypertensive emergency due to malignant hypertension, because cocaine is common abroad. They snort cocaine and the BP shoots up and then they can die because of brain hemorrhage or myocardial infarction. Now, what are the drugs which are recommended for malignant hypertension? We can start with the first entry that is given as labetalol, or we can use nicardipine in the patient. Then is sodium nitroprusside, obviously eternal favorite with any physician because it gives you minute to minute control. A fourth drug is a ACE inhibitor that can be given intravenously. That's a question for you guys. I give you 5 seconds while I write it down. ACE inhibitor that can be given intravenously. The answer would be enalaprilat. So any of these drugs can be used. Though in Harrison in the table first labetalol is given, so I mentioned it accordingly. Labetalol, nicardipine, sodium nitroprusside and enalaprilat in a patient. I would like to state the fact that if the question only uses the word hypertensive encephalopathy, that is also an emergency because CNS is involved in the person. He has become unconscious because the blood vessels of the brain have undergone a protective spasm. For hypertensive encephalopathy, you answer sodium nitroprusside, not an issue. But if he says malignant hypertension, then in most of the books, first labetalol is given, sodium nitroprusside is given a little in the end. Why? Because lots of time nitroprusside can cause a sudden precipitous fall of the blood pressure, and because the blood pressure falls very fast, so there is a possibility that the person can deteriorate. His coronary ischemia might be triggered, or for that, because this was an old person, right? His coronary ischemia, his coronary reserve is already compromised. So his coronary ischemia can be triggered. So therefore, we are a little cautious while using sodium nitroprusside, especially in old people who are having an abrupt rise of blood pressure like a malignant hypertension. The same reason will make you understand that even in neurology, I've spoken about it and I'll speak again today, that when it comes to stroke patient, like acute ischemic stroke patient with hypertension, we are not very comfortable giving sodium nitroprusside because the moment the BP will fall fast, then the cerebral perfusion pressure will also fall. You see, there is a formula that is cerebral perfusion pressure is a difference of mean arterial pressure minus intracranial pressure. If you will cause a sudden fall of mean arterial pressure, then cerebral perfusion pressure will fall. You will anyway lose the patient. So in acute ischemic stroke with hypertension, if a person is having a blood pressure more than 185 by 110 millimeter of mercury, then thrombolysis cannot be done immediately. Ideally, thrombolysis should be done within 4.5 hours of presentation of or development of symptoms of acute ischemic stroke. Here, I would first like to decrease the blood pressure of the patient using drugs like labetalol, or in fact, first drug that is written in Harrison for any patient having hypertensive crisis with stroke is nicardipine. Then labetalol, then sodium nitroprusside. So do remember the sequence here. For person of acute ischemic stroke, presentation has occurred within 4.5 hours. He is a candidate for thrombolysis. You are supposed to lower the BP before you initiate thrombolysis. Now, why is it so? Well, the logic is that thrombolysis itself can cause brain hemorrhage. And if the brain hemorrhage occurs in a setting of high BP, it can be very, very fast. So he says, don't rush into thrombolysis immediately. First, lower the BP to the critical value. This is the cutoff for intervention. If the BP is more than 185 by 110 millimeter of mercury, you should first lower it using first nicardipine / labetalol / sodium nitroprusside, and then initiate thrombolysis in a patient. Then he's also mentioned that if a person is not a candidate for thrombolysis, like a person of acute ischemic stroke, he came to the hospital after 4.5 hours, or he came after 6 hours, whatever, he's a delayed presentation, then you will not do thrombolysis. Then he says you are to lower the BP of the patient only when the systolic is more than 220 and diastolic is more than 130 millimeter of mercury. Why is he saying this? Is because in patients who are having stroke, the perfusion of the brain is already compromised. If you will lower the BP of the patient, then the cerebral perfusion pressure value will fall. Normal cerebral perfusion pressure is 60 to 80 millimeter of mercury. That is what we want to maintain in a case of stroke, and that should not be done by causing a fall of mean arterial pressure. You can study the raise ICP topic separately, but the main crux of this particular slide that I want you to understand is that when will you intervene to lower the BP in acute ischemic stroke patient who's a candidate for thrombolysis, 185 by 110. Don't do thrombolysis right now. First lower the BP, it will take few minutes only, and then initiate thrombolysis in the patient. Apart from this, I also wanted to remember that in a hypertensive crisis, if a person is having a MIE or unstable angina or acute decompensated congestive, ADCHF is acute decompensated congestive heart failure or post-operative hypertension, then for these patients, the drug that is recommended first line is IV nitroglycerin to control the hypertensive crisis. I repeat my statements once again. If he says encephalopathy, the answer should be given primarily as sodium nitroprusside. However, if in the question he uses the word malignant hypertension, then you should answer it as labetalol, nicardipine, then sodium nitroprusside. First answer would be labetalol, then nicardipine. If he's saying stroke, then the first answer is nicardipine in the patient. So all these minor aspects have to be remembered by you guys. You need to put an effort to remember it. And if it is MI unstable angina, then it is IV nitroglycerin. This is a table that I'm discussing from Harrison, which should be remembered. Let's take up one more entry so that you feel more comfortable here. Adrenergic crisis. That could be pheochromocytoma patient who's having an adrenergic crisis during pheochromocytoma surgery. So what will we do? We can use sodium nitroprusside and we can back it up with phentolamine. That is a non-selective alpha blocker. So it will help in controlling the surge of blood pressure which will occur during tumor manipulation during adrenergic crisis, which is caused by pheochromocytoma surgery in a patient. So these are the aspects that I want you to remember. Lastly, I will mention regarding the target blood pressure and the goal blood pressure which is to be achieved in patients of hypertension. In the 20th edition of Harrison, for all cases of hypertension, whether essential or secondary cases, he has mentioned a blanket statement that if you can achieve a blood pressure between 135 to 140 systolic and 85 to 90 diastolic, that means that you have done a job perfectly. However, he has mentioned that if a person is having a coexistent diabetic nephropathy, the patient is documented to have albuminuria, then the ideal blood pressure of the patient should be kept as less than 130 by 80 millimeter of mercury if tolerated. The reference here I'm mentioning, the page number is 2117 of Harrison 20, where it is mentioned. And in this chapter I've been forced to give references because this topic is literally a controversial one because various cutoffs are given in various books. Why he has said a cut of 130 by 80 is simply because the damage to the kidney has already occurred. So I'm just going into a damage control mode in the patient. If he says patient is having malignant hypertension, remember I told you people with malignant hypertension, if not treated properly by drugs that I discussed before you, they will die in the next 6 to 12 months. Then in these patients, the target blood pressure that I want to achieve on admission is at least 160 by 110. Like let me say the patient came with blood pressure of 220 by 125 or 220 by 130, whatever in round figure, then I can achieve a blood pressure of this by using drugs like labetalol or nicardipine in the patient. The mean arterial pressure of the patient should be reduced by at least 25% over 2 hours. I'm not saying over a matter of seconds or minutes, I'm saying over a matter of 2 hours because I also want to give some time for the brain to re-establish or reset its cerebral perfusion pressure. Otherwise, if you cause a sudden lowering of mean arterial pressure, the brain perfusion will be lost and the encephalopathy component of the malignant hypertension will be substantially reduced in the patient. So these are the cutoffs which are given. I'll repeat them again. For general population, essential secondary hypertension, Mendelian forms, it is 135 to 140, 85 to 90 millimeters of mercury. And diabetic nephropathy, a little more aggressive control, malignant hypertension is the emergency, so 160 by 100 millimeter of mercury. So these are the drugs which are recommended for management of hypertension. And to finish the topic, I will just go back to my first slide and mention this very peculiar statement which is given in Harrison for the current diagnosis of hypertension. He says that instead of establishing these cutoffs with isolated values, like earlier we used to say, okay, check the BP at least 3 times, and if it is more than 140 by 90, you can take an average of the 3 values, that would be the blood pressure value of the patient, and treat accordingly. Now he says that because we are having technology, you go in for ambulatory blood pressure recording, and you can, by that software, you can then analyze, awake BP is how much, sleeping BP is how much, and if awake or sleeping, either of the two, if it is more than these values, it is a definition of hypertension, and treatment of the patient should be recommended. And this will correspond to a clinic blood pressure of 140 by 90 millimeter of mercury. So thank you so much for listening and having the patience to hear me out on this topic. Don't get bogged by the multiple figures that I've told you. Just get the basic concept right. I mean, if this particular slide is imprinted in your brain, you are bang on target to understand the topic of hypertension. And as you will see more cases, you will realize that if you are trying to be too strict, like I'll just say that again, diabetic neuropathy patient coexistent with diabetic nephropathy. If I'm too aggressive, BP will fall, he will fall in the bathroom, there would be head injury in a patient. So with experience, you will be able to handle your hypertension patients relatively better. Thank you to hear me out.